Hi guys, my name's Christy. I'm one of the PGY2s if you don't know me, and I will be giving afternoon report today. Okay. So here we have a 56-year-old female. She has past medical history of GERD, OSA on CPAP, recent hospital admission for community-acquired pneumonia, which was treated with a total of 7 days of Levaquin. And she comes to the ED with worsening dyspnea, cough for 2 days. The patient's daughter brought her in after measuring her temperature, which was 100.8 degrees Fahrenheit at home, and a pulse ox of high 70s to low 80s. She says she has mild improvement of her symptoms since her previous admission, which was about 1 to 2 weeks ago. She completed the whole course of antibiotics she was prescribed, but her symptoms haven't completely resolved. She's endorsing cough with moderate amounts of light green phlegm, which is improved from the dark green during her previous admission, and also has some fevers, chills, and fatigue.
So I was thinking if we can stop here in the HBI, that's excellent, Christy. And because it's been a long day, we're kind of reaching the end of the week. It was a step back in what we're doing, and we're thinking a pretty broad differential diagnosis. And obviously, guys, if you disagree with me, please type it in the chat. But I do think this is a perfect case so that we can discuss clinical reasoning and we can learn a few terms so that, all the afternoon reports that we've been doing so far kind of fall into place. And then maybe starting January, we know a little bit more why we. So when we talk about clinical reasoning, we're talking about obviously information, we generate a hypothesis of any possible diagnosis patient may have, right? And then we select the appropriate tests that we want to confirm or refute that hypothesis. Determine, an optimal diagnosis that will ultimately lead you to the treatment. And that's what we'll be doing in the next few slides. And it sounds pretty simple, right? That's our day-to-day. Now, what we need to know is that really clinical reasoning is something that's quite imprecise, which means, many situations don't really have a right answer. It's something that's probabilistic, so we can still make a misdiagnosis. And this is a perfect case to go over this. And obviously, it's also going to be continuously updated so that we are going to get new pieces of relevant. And we'll see how that helps us advance in this case, right? What I want to do today is just sort of generate a discussion. And this is, like I mentioned, a simple case to do this based on the slide. There's a lot of information, which is usually the case when we go see a patient in the ED. Okay. So while I'm talking, I want you all to, if you would like to participate, obviously, type in the chat which symptoms you would highlight in this case. I want to know key pieces of information. Let's say you're receiving a sign up from the emergency department and you're making notes and your notepad or whatever you made notes. Anything that can help you build a chief complaint, right? Because we notice here we jump right into the HBI, right? What would you be focused as this patient or focused on as this patient is admitted to your service, right? This is sort of something that we do every day. Like I said before, we make use of illness scripts. And we've heard this word before, but up until this year, I didn't realize just how important this was. We organize clinical information, right? And it's sort of our own mental summary of your knowledge about certain diseases. So you have 3 different components, and I'm still waiting for people to type in the chat, like I said, words in this HBI that can lead you to designing your own complaint. So the 3 main things in an illness script: who's at fault or what's the fault, pathophysiology, right? And thinking, what are the features of my patients? What are the contextual factors that play a role here? And then the consequences, which is what we see when these patients walk into the emergency department. What signs and symptoms are helping me describe this disease? So I see here that for some, it's going to be the dyspnea, the cough, which is something that we take with a grain of salt. Some people measure their oxygen saturation with, you know, the fever, the hypoxia, and the cough seem. I agree. Those would be the things that I would focus on when I'm building a chief complaint. So what is that? You know, what is the patient telling me that the reason for this encounter? What's my presenting problem? Why am I even walking to the emergency department? I agree, Taran. The recent hospitalization will be something important to know how, you know, afternoon reports, we usually also
We're just going to change the mic. I think it was going in and out a little bit.
now.
Sounds, we can start now, I guess.
Yeah, can you hear me? Sorry, what's going on?
It went out a little bit in the end.
Oh, no, it always happens with my cameras. All right. What was I saying? We're talking about how we build diagnostic frameworks, right? And if anyone listens to the, you know, clinical problem solvers or the curbsiders, which I highly recommend, they walk you through this, right? And that's just mainly, you know, a list, a categorized list of, you know, technologies for a certain symptom, right? Or a certain finding in a physical exam or a lab abnormality. And it really, really helps us hone it into a diagnosis. So for today, I think, other than obviously discussing this very interesting case, I want to have the, you know, objective of kind of improving that diagnostic skill, clinical reasoning. And we're going to do this through, like I said before, problem or presentations, which will get someone to participate and give us their idea. And we'll talk about illness scripts and create a diagnostic schema, hopefully for at least two of those main symptoms, dyspnea and cough. I'm sure that as we're talking, you know, these symptoms, dyspnea, cough, fever, kind of triggered a list of differential diagnoses. And I know that at least in my mind, many illness scripts are kind of shuffling. I want you to throw out there, you know, whether you want to mute yourself, it's fine. If you want to type it in the chat, what differential diagnoses come to mind, at least with these three symptoms? I know there's a lot going on in this HBI, but let's say someone's walking in with cough, dyspnea, and fever. What are some of the things that come to mind?
It can be pneumonia. Another thing could be cancer. It could also be cardiac related. Like fever could be non-specific. Someone that has also an infusion can have cough, dyspnea, and fever, maybe a low-grade fever.
Walk me again through those. You mentioned pneumonia, you mentioned cancer. Can you remind me, what was the third thing you said?
Maybe a pleural effusion.
Pleural effusion. Thank you, Chris. Does anyone else have anything else?
I think PEs sometimes also can be seen with low-grade fever.
That is so true. Yeah. Melissa, what else?
Let me just ask everybody, if this patient got treated for pneumonia and now is coming with similar symptoms, here you mentioned some, but what are the complications of pneumonia?
Pleural effusion.
Everyone's saying pleural effusion, and that's great. I would say more specifically empyema, right?
There we go.
Thank you,
Or long
Shabari.
abscesses, right?
The other thing to take into consideration here is that, you know, normally it's okay to accept the diagnosis that the patient comes with. The patient was diagnosed with pneumonia and she got treated. She seemed to get better. Now she's not any better. I think it's okay to question the diagnosis of pneumonia as well. Of course, we will have to review all the information on how that diagnosis was made. But if the patient was having, let's say, a lymphoma with lung infiltrates from lymphoma, you know, she won't get any better. The disease is going to progress. I know that Christopher mentioned cancer. You know, to me, I would think first, you know, in terms of the cancers, to me, leukemia, lymphoma would be higher on the list, presenting with fever, compared to lung cancer, even though we know that, you know, particularly small cell can do that as well.
Well, thank you so much, Dr. Briglin. Exactly. And we'll go back to the history and we'll take a second look at all the other extra information. I know this might be hard. Christopher, actually, do you mind helping me since you started sharing? One of the things that I used to do, you know, was to create sort of a mental Venn diagram. So you kind of pick the major problems that a patient may have and you see where they overlap. See what the most likely diagnosis. What I'm going to do is I'm just going to show you what a Venn diagram looks like. We'll go back to the initial slide and see what are the things. So I don't know. So let's see. So let's say I'm like, well, COVID might present with fever, and if you want to say pneumonias, present with fever, they're both presenting probably with shortness of breath. They're
Oh, maybe we have to do the like fever, cough, and shortness of breath. And then there is one where 2 circles overlap, and then a part where the 3 circles overlap. Because
exactly. And we can simplify it if you'd like. Just based on, we're going to go back because there's more information in the HPI and sort of mentally, obviously, because we can each do this from home. I want you to help me, Christopher, find where you think, your 2 top differential diagnoses, the major problems, where they would, sort of overlap and what you think the most likely diagnosis will be. So Christy, if you want to share the HPI slide, that would be great. And then we'll talk a little bit more. I'm going to go back to, what are symptoms? I see Shabby. Oh, no, this is the same. Thank you for everyone that typed in the chat. What other things are there to these like major problems would help you in your diet? What are you thinking of the 2 top differential diagnoses here?
The top 2 differential diagnoses, of the ones that were listed there, I think, so because of the saturation on the high 70s, low 80s, COVID will be high up. Other things that can cause also fever, low desaturation, especially in the case of recent admission of pneumonia and despite the 7-day course not adequately failed for antibiotics, could be an abscess or empyema.
Thank you so much. That's fantastic. How about you, Jonathan? You want to give me a hand? So he mentioned COVID would be high in his differential, and then he mentioned, given the history of the previous else that you like to add, maybe 2 other your top differential diagnosis.
Yeah, I would consider, since he got Levaquin, we're still like other organisms could still be not covered. So could still be a pneumonia that wasn't covered, or could be a pneumonia that had complications. So empyema, abscess, and I still put PE with pneumonia at the top.
Okay, and that's fine. I think when we see a patient, we may initially, and that's excellent. Thank you so much, Jonathan. sometimes, and I felt like I did this often when I was a resident, I would anchor pretty heavily on a diagnosis. And like, if you nail the diagnosis, then you're a genius, but if you anchor on a diagnosis and you miss it, that's kind of biased. But it's not a bad thing, right? Like, we try to do this every day because we kind of have to rely on our reflexive thinking. And I think that's sort of where this is at, right? Like, we're COVID times, there's certain things that we see in the history that might, prompt cover. Now, when a patient presents with dyspnea, and this is something that we need to make sure that we know, even though here we have a sign for hypoxia, remember that dyspnea is a subjective sensation of running out of air, right? Your patients don't feel like they can breathe fast or deep enough, right? And that's why I mentioned history will be crucial here, because we need to know if there are any cardiac or pulmonary symptoms, and that's usually because cardiac and pulmonary will be the most common causes of dyspnea, right? So we will look at onset, duration, whether this happens at rest or exertion, which are some of the questions I expect you guys to ask. Online that someone called the dyspnea pyramid, and I think if I can just how do I real drawings? Okay. So basically what they're suggesting is that we can think of this the different components of it. Basically, they would say like we can think of the delivery, obviously like blood and when they think of lungs, they also like to put this up in airway. Sort of like the parenchyma, the alveoli, the vasculature, and then if you saying we do it now, but because my drawing isn't that good, if you go online, there's like perfectly drawn pyramids out there. So quickly, James, what thing of the things that we mentioned would affect the airway?
So the airways, we were talking about like pneumonias, COPD, asthma, any sort of reactive process.
Fantastic. All right. Andrew, how about the vasculature?
Like vasculitis or
Perfect. Yeah. And we mentioned it before, PE, something that you may see pulmonary hypertension be one. Thank you so much, Andrew. A lot of cameras off. I'm not sure why, guys. I hope that you're still here with us. I know it's been a long day. Avery, how about when it comes to the parenchyma, the alveoli? And I know we mentioned pneumonia. What other things that we just saw in the previous lecture?
Pulmonary edema, cardiogenic or non-cardiogenic.
Great, Yoni. That's wonderful. Yoni, how about when it comes to delivery? What other things in delivery? The heart. What problems with the heart will lead to dyspnea?
Oh, I think like anemia, severe anemia, like methylmaloglobulinemia, CO poisoning, carbon monoxide poisoning.
So you mentioned a few other things there. Perfect. And then we would have here acidosis and how it affects the, sort of oxygen in the blood. And then obviously we would have in the top, those rare conditions like chest deformity or immune conditions when you're thinking of, maybe a myasthenia gravis, or if you're thinking of Guillain-Barré or other neurologic disorders, right? So this is helpful. I mean, again, go online, feel free. I know I'm coming in and out. I think you're typing that to me. But if anyone cannot hear me, just feel free. Fatma, perfect. Adelaide.
Yes, hi, how are you?
It's my voice. I'm speaking too softly. Yeah. Okay. I'll try to speak. I see. Okay. I'll try to speak louder then. There's a lot of echo here. All right. Perfect. So that's the thing. And whenever you have these patients coming in, orthopnea, pedal edema, nocturnal paroxysmal dyspnea. Obviously, you're going to be thinking of congestive heart failure. Someone that's coming in with chest pain, anginal chest pain, then you're thinking ischemia. And if it's paired up with dyspnea, you're thinking of LV dysfunction. I mentioned it before, someone that comes in with, acute shortness of breath, then you may be thinking of a PE. Let's say someone comes in with just chest pain. Sometimes spontaneous pneumothorax can occur, and there are rare conditions. And I was looking up like where that would happen when it's not in the case of some sort of trauma. GERD, aspiration, it depends on like the age of your patient, exposures that they may have, right? So we're gonna go back to Christy's presentation. You're gonna ask all the questions that you may need in this case. And I want you to challenge yourselves to kind of distinguish signal and noise. Okay, so whenever you did all a great job, common things being common, that anchoring is normal and is fine. Frame your patients with and without that potential noise that we're going to be hearing about when we do our review broadly. And then whenever you do that, and you're trying to kind of say, well, maybe this is a cardiac event, or it's an exacerbation of a pre-existing pulmonary condition, create 2 problem representations, okay? And then go from there and see if just based on your differential, we can get to a diagnosis. So Christy, I'm gonna stop my share so that you can put up your slides.
Okay. Can you see that? Okay. So just going through some of her past medical history, GERD, OSA, and in terms of surgical history, appendectomy a while ago, as well as some lumbar spinal surgery. Her family history was largely non-contributory. She has no allergies that she knows of. And in terms of medications, she's only on daily omeprazole, 40 milligrams. She does not smoke. She does not drink alcohol or do any other drugs, and she has no recent travel. On review of systems, she has fever, chills, fatigue, like we talked about, some throat pain with her cough, dyspnea, and some sputum production. She did not have any chest pain, no palpitations, no orthopnea, and other review of systems was largely negative. I don't know if anyone has any other questions before moving on to the physical exam.
Hey, Christy, this is Raul. I was just curious to know if there was any myalgias or arthralgias back when she first got admitted to the hospital for CAP, or if she had like any other like symptoms like sore throat like back then. Not now. I know now the review system, but back then.
Yeah, I don't know about sore throat, but no arthralgias or I mean, for past hospitalization, no.
You're thinking because she's not complaining of sore throat, Raul? Is that where your question's coming from?
Yeah, my thought process is like she initially had some sort of viral pneumonia, and then she got treated for something that maybe didn't quite respond to to antibiotics. Yeah, I think Dr. Singh is saying something like, yeah.
What do you mean? Okay.
Yeah.
Okay, thank you. And then Fatma, she wants to know if she's complying with antibiotics. Not just saying, yeah.
She completed all.
Go ahead. Do you know that information? Was it compliant?
With the antibiotics? Yeah, she took all of her antibiotics. And for the first admission, viral swabs were negative, and I don't think there was a sputum culture.
What is her background? Like, is she from the US? Any history of incarceration or
Sorry, can you repeat that?
any history of incarceration?
No history of incarceration, no.
And where is she from? Like,
I don't know exactly where she's from actually, but she lives in the US currently and she didn't immigrate from anywhere recently at least.
okay.
That's really important to know. Why were you asking that, Christina? What's in your mind?
I mean, like, I guess if she is from any other place, like where is higher prevalence or other organisms like TB or something like, or parasites. So yeah, that will build my differential.
Fantastic, great. Any unintentional weight loss, Fatma's asking?
No, no unintentional weight loss.
Previous pneumonias? Like other than the most recent one, I mean, childhood diseases.
1 year ago, prior to the, not including the last one, she was also admitted for pneumonia, got treated with antibiotics and improved. No sick contacts.
And she's like non-smoker, like never smoker, right?
Never smoker.
When she was treated for that previous pneumonia, was she also admitted, or was that done as an outpatient?
She was admitted. So
twice she was admitted?
Yes.
Okay, and both times she improved?
A year ago, yes. Like a year ago, she was admitted, treated for antibiotics and improved. And then a week or two before this, this presentation, she was admitted.
Do we know if she was vaccinated against pneumonia?
That I am not sure of.
Okay, and how severe was her GERD? Was it like a regular GERD or was it something very severe?
No, it was not severe. It was just, yeah.
Okay, because in somebody with recurrent episodes of pneumonia, you need to wonder, right, about recurrent aspiration.
And on that point of GERD, I'd also like to add some of these atypical dyspeptic symptoms get labeled as GERD. The patient might have something like gastroparesis or something else which can predispose them to recurrent aspiration pneumonias. So it's important to know if it's like documented GERD by endoscopy or some kind of monitoring, or is it just dyspeptic symptoms which are labeled as GERD, but the patient might actually have, severe gastroparesis causing recurrent aspiration pneumonias.
That's a very good point. I don't think she had any endoscopies in the past or any pH testing, so that's a good point.
I have a question for you, Anga. Let's say she's there's some acid suppression going on, she's appropriately medicated. Would that still be the case? And would that develop even with the gastric content itself?
No, so I think more than the GERD, I would be worried about something else which is being labeled as GERD, like gastroparesis or some kind of lower esophageal motility dysfunction, which is causing recurrent aspiration, because that's actually a more common cause for pneumonias, and GERD itself might, like if the patient has simple GERD, that might not cause pneumonias, but something like gastroparesis would be more dangerous.
So even if our patients are on the proper medications, whatever, question the history, and we'll go over this a little bit later as well. So Farah's just confirming her sputum, I guess, production is improved compared to her recent.
Yes.
Christina's asking if she has any history of asthma, allergies, atopy, and I was thinking if you can tell us what she does for a living.
She does not have a history of asthma, no known allergies, or history of atopy.
And what does she do for a living, Christy?
Oh, she does not work. She stays at home.
Iris, I'm curious, why were you asking about her sputum production?
Mainly because I'm thinking that whatever she had may have been, treated, but now she's presenting with something else, especially because the symptomatology is slightly different. It's very slight difference, but I think it's an important difference. First the sputum and then the myalgias.
Like what, for example? Like a...
What is it? Sorry?
I'm not sure I follow. I'm so sorry, Ferris. You mean like she's presenting with something Like an acute and chronic exacerbation, or
No,
what are you
so
referring to?
it sounds like she did have, like, if she had a community-acquired pneumonia, it sounds like it's been treated kind of and improving, and now she's maybe presenting with a different pathology because she has different symptomatology, including maybe less emphasis on the sputum and more emphasis on the myalgias.
I see what you mean. Any other questions? Medical history, conditions, medications, recent admission, compliance with medications. Living situation, contact. We need more information. Christy, if you want to share.
So for her physical exam, for vital signs, her blood pressure was fine. Her heart rate was 96. She was afebrile. Respiratory rate was 18, and her oxygen saturation was 84% on room air and improved to 93 to 98% on 3 liters of nasal cannula. She was slightly overweight. And overall, she was a tired appearing middle-aged female. She didn't appear to be in acute respiratory distress. However, her oropharynx was non-erythematous, no lesions or exudates. Her cardiovascular exam was pretty much unremarkable. And in terms of her pulmonary exam, she had diffuse crackles bilaterally, no wheezing noted. And her GI exam was benign, as well as the rest of her exam, no rashes noted. And she had no swelling or edema.
The oxygen saturation, was it measured on the 3 liters?
On 3 liters, it improved to 98%.
Okay, perfect, thank you.
These are just some of her labs, just some mild leukocytosis, but otherwise they were pretty much unremarkable. Her BNP was not elevated. She had negative troponins, and she was COVID negative, and also flu and RSV negative.
Do you remember the differential of the white cell?
I do not. Sorry.
Just say it was a CBC without a diff. It was done the ET. We didn't have those results.
Sorry, Sandy. I couldn't hear what you were saying.
Brett, can you hear me now? I'm speaking as loud as I can. Okay. Brett, do you mind? Hear me? You can't hear me? No?
I can hear you now. You just cut off.
I don't know what to do. Subrata, do you mind summarizing the physical exam and lab findings so that we're on the same page? You first have to unmute yourself though. Thank you.
Can we go back to the physical exam page? Like just so that I don't miss. Yeah, okay. So like to mention that we have this patient who is comes in with like dyspnea and was found to have tired appearing, grossly normal physical examination other than positive findings of diffuse crackles in the bilaterally. I'm not really sure if it's on the just throughout the lung fields or it was specific to lower fields, and is saturating fairly well at 3 liter nasal cannula. No focal deficits and no rashes noted.
Awesome. And it was throughout the entire lung field, sorry. Okay. They got a chest x-ray when she first came in, and it read as mild improvement in bilateral lower lung zone airspace opacities with the reticular pattern compatible with interstitial/atypical pneumonia.
That was something interesting. So we kind of established the time course in the HBI, what we thought we did, but I think we need to be careful with sometimes how we take the history and what people say. Chronicity, it's not always what our patients tell us when they first notice their symptoms, right? If you find someone on exam that they have any clubbing, which we didn't see, and we didn't even see any signs of fluid overload, and we're confirming sort of with the X-ray that we have some imaging of perhaps, a reticular pattern, perhaps of fibrosis. We're not necessarily sure if this is an interstitial or atypical pneumonia, as our radiologists are suggesting. So just be open to, like we said before, acute and chronic processes, right? We don't really necessarily know that much about this patient, right? Reminder, I'm not going to change to the tablet in the interest of time, but we have different abnormalities on X-ray. Remember that, the opacities are far more common than the decreased density that we may find in some conditions. And when we see an X-ray and with opacities or increased density, there are 4 different patterns. So it's either a consolidation, which remember is just anything that fills the alveoli, right? Whether it's cells and a pneumonia, pus, blood, whatever's, maybe in a cancer, we have an interstitial pattern that it's filling whatever's supporting the lung parenchyma. And then that kind of gets subdivided in different categories. You have nodules or masses, anything that occupies a space. And then you have atelectases, right? Which we see pretty often. And we see in obese patients and whatnot, which might have been the case initially in this patient. It's just that increased density because there's some volume loss. But really, when we see a what they call reticular pattern, what we know of these patterns comes from a CT image, and a high resolution CT is what we look at, right? So maybe the X-ray is kind of hard to tell or determine whether there's interstitial lung disease or not. And yes, the most common pattern that we'll see in X-rays when that's the case is the reticular pattern. But you have to remember that the most common cause for this is actually an acute exacerbation of heart failure when there's that interstitial edema. And remember how sometimes you can even seek, what do you call these, curly B lines, which are the 2 to 3 centimeter lines that are coming from the pleura. Sometimes we see them and we get excited, but remember, even for something that's common, we also have a differential for that. And the 2 main diagnoses there, yes, either an acute heart failure with interstitial edema, or maybe some sort of, cancer spreading through the lymphatic, system. Now, interstitial pneumonias, like they're suggesting in this case, could be also wide-ranging things. And whenever you're studying this, remember that there's different time patterns as well. So if something's chronic or you suspect it's more than an acute process, even though the most common things could be, viral, it could be a mycoplasma pneumonia. And in some of our patients, we see pneumocystis. There's a long list of things where you have to think of, medications, you have to think of autoimmune conditions. You also have to think of maybe pulmonary conditions. This patient had OSA, was on CPAP, keep that, differential broad. We asked about potential, tuberculosis, exposures, where's she coming from, all those things to keep in mind. And I remember someone also asked for the possibility of, symptoms or common symptoms of an oncogenic process as well. I'm thinking maybe there's a cancer going on. Now, this is the image that we have on X-ray. I'm going to just let you, again, go ahead with the rest of the presentation, Christy, I guess, because we may not, unless we want to talk about cough for a second. What was if you want to go to your next slide.
Oh, it was just the one-liner.
The one-liner, perfect. So let's pick someone who has been with us for the entirety of the presentation. How about Christina? Do you want to help us with your one-liner for this patient?
Sure. So I would say this is a middle-aged woman with, I don't know, coming with a pseudo-acute onset of productive cough, fever, and shortness of breath. In the setting of recent hospitalization for pneumonia, I think her vitals were like, it was significant for hypoxia, like I think it was in the low 90s. And I think it mild fever, like 100.8. Her physical exam was remarkable for diffuse crackles bilaterally. What else? And I guess the lab work showed like mild leukocytosis. And that's it. Yeah.
That's very, very good. That's a great summary. Perhaps you want to just, transform it into acute hypoxic respiratory failure, requiring oxygen supplementation, just to summarize. But Christy will share her, problem presentation, her one-liner.
Yes. So very similar, middle-aged female, recently hospitalized with community-acquired pneumonia, who presented with subacute onset dyspnea, productive cough, fever, found to be an acute hypoxic respiratory failure with mild leukocytosis and reticular bilateral lower lung opacities.
Sorry, let me just make a comment. To me, the one-liner should be the step to coming up with the right answer to what's going on. So to me, the other piece of information that I would include here is that her recent hospitalization was for a pneumonia treated with 7 days of levaquin. And I think that's a key piece of information, because if we're now dealing with a reticular pattern and we're thinking maybe we didn't cover the right bugs, the fact that you got treated with levaquin is really very important.
Agreed, thank you.
We can't really briefly talk about cough. I know it's such a broad differential diagnosis that we may not be getting far, but I just thought it was interesting to talk shortly about cough. In 3 weeks, and I love how both Christina and Christy were saying, well, this is a subacute process. 3 to 8 weeks would actually describe a subacute process, and then chronic is someone that's coming in with more than 8 weeks of cough. I found something really cool online. I don't know this person. This is a YouTuber. He shares interesting stuff. Basically, what we know is that cough is such a complex reflex arc. I know that it's dependent on the stimulation of different receptors, and they're everywhere. I was reading up, and we even have them in our esophagus, our diaphragm, our stomachs, and the cough receptors are definitely, divided in, or definitely, sensitive to chemical and mechanical triggers. Chemical triggers, this, we mentioned that before, acid, heat, whatever, and then mechanical triggers, touch, and this is something that we explore. Then that, and this is something that if you want to go to the video, it will explain it, how it travels through different afferent pathways, and they kind of both, the afferent and the efferent pathway use the vagus nerve. Thank you so much, Rafa. He's sharing some information about antibiotic coverage. The main thing to know is that it's a higher cortical center that kind of controls cough. The most common thing, and again, I have the citation here if anyone's interested in taking a look, is that viral respiratory tract infections are the most common cause of cough. And I love this diagram where they just kind of divided it in upper respiratory tract, which we call the common cold, lower respiratory tract, which we kind of call acute bronchitis. One of the main things that we have to look for is obviously if there's a presence of red flag. Always want to screen for any life-threatening conditions. And if you read through the list, mostly you'll talk about hemoptysis and patients that have had some sort of weight loss, any signs that may be concerning for cancer. Peripheral edema, like we mentioned before, with some weight gain, thinking of congestive heart failure, someone with a recurrent pneumonia, and particularly if your x-ray is just revealing the same location for the pneumonia, there's some process going on, and then vomiting, and people with GERD may have some sort of foreign body aspiration. All those are causes of acute cough. But most importantly, like I said, could this be a PE? Could it be like in this case, maybe a recurrent pneumonia, which we mentioned was properly treated, congestive heart failure. This, Christina mentioned before, in high-risk endemic areas, considered TB, or could it be just some sort of other, mycoplasmic infection? So, Christy, is there anything else that you want to share about this patient that might help us reach a diagnosis?
Yeah, so upon further questioning, it turns out she has about 6 birds in the household and recently got a new pigeon. So that was an important piece of history that kind of led us to get further imaging and kind of put everything together. And I can go through the rest of the presentation. So we got the high resolution CT and it showed severe diffuse bilateral multifocal 0.1 to 0.2 centimeter central lobular ground glass nodules. It showed some bibasilar linear opacities compatible with atelectasis and a pulmonary mosaic attenuation pattern, which is very characteristic for hypersensitivity pneumonitis, which was our ultimate diagnosis in this patient. So for the hospital course, she was started on doxycycline and given a steroid course. She improved pretty rapidly, also consistent with the diagnosis, and eventually required no oxygen support. She was discharged on prednisone 30 milligrams daily, and it was tapered 2 weeks with pulm follow-up. And the family reported that they moved the birds to the second floor apartment. So I just wanted to briefly talk about hypersensitivity pneumonitis. It is also called extrinsic allergic alveolitis, and it's basically an immunologic reaction occurring within the pulmonary parenchyma caused by hypersensitivity to an inhaled agent. So whether that be microbial, avian, animal antigens, or other organic compounds. And it's basically broken down. You can categorize it as acute or subacute. In acute hypersensitivity pneumonitis, you have exposure to some culprit antigen, which leads to specific IgG antibody formation to that antigen. And as you get subsequent exposure to this antigen, immune complexes form, you get an influx of neutrophils, and this causes this episodic lung inflammation. With the subacute chronic subtype, it's mainly thought to be CD4 positive T helper cell mediated delayed hypersensitivity causing granuloma formation. It can also be classified as non-fibrotic or fibrotic, and non-fibrotic means it's purely inflammatory. Fibrotic meaning it could be mixed inflammatory and fibrotic, or just purely fibrotic, and this is based mostly on imaging or biopsy. So some occupations and activities associated with hypersensitivity pneumonitis is farming, dairy cattle workers, exposure to water reservoirs, bird handlers, other animal handlers, some grain or flour processing, textile workers. And these are some of the major causative antigens for each of them. The main clinical features associated with hypersensitivity pneumonitis is dyspnea and cough. Less common is chest tightness, constitutional symptoms like fever, chills, weight loss, or malaise, but it can still occur. Main physical exam findings is tachypnea. You can have focal or diffuse crackles, and chest x-ray can be normal a lot of the times, or it can demonstrate micronodular or reticular opacities like in our patient. So evaluation and diagnosis of this condition. History, as we now know, is kind of the main and most important in terms of diagnosing the condition. In terms of labs, the diagnostic utility of serologic assays for specific IgG antibodies is controversial because the sensitivity and specificity appears to vary with different antigens, smoking exposure, duration of exposure to the antigen. And just because you have a negative serology doesn't mean hypersensitivity pneumonitis is completely ruled out. So it's controversial on whether it's helpful or not. It can definitely indicate exposure to the antigen, but a lot of patients with exposure are asymptomatic as well. So it's not super useful. And then PFTs, it can be, you can see a restrictive pattern with them and decreased DLCO, but it's largely non-diagnostic. The main imaging that's useful in diagnosis would be a high-resolution CT. And you'll see in non-fibrotic hypersensitivity pneumonitis, ground glass opacification, small central lobular nodules, usually less than 5 millimeters, lobular areas of decreased attenuation and vascularity due to air trapping. And then in fibrotic hypersensitivity pneumonitis, you can see irregular linear opacities, some coarse reticulation, traction bronchiectasis or honeycombing. You can also see ground glass attenuation with the fibrotic subtype, as well as the central lobular nodules. And you can see what's very classic of hypersensitivity pneumonitis is the 3 density pattern, or this like head cheese sign is what it's called. And it's a mixture of ground glass opacities and a mix of some normal lung parenchyma, as well as hypoattenuation from air trapping. Some additional studies that can be done is a BAL, lung biopsy, or an inhalation challenge. But largely, if the patient has a clear history of an exposure, and if they have very typical high-resolution CT findings, and if they respond to antigen avoidance, you really don't need a bronchoalveolar lavage. If they do have a history of exposure and some compatible high-resolution CT findings, but not typical, you can do a BAL, which will show lymphocytosis of greater than 20% usually. And if they have all 3 of these things, then a biopsy is usually not needed. If they don't really have 2 or more of these findings, meaning history of exposure or typical high-resolution CT findings, and a BAL is inconclusive, then most likely a biopsy will be needed. And so for treatment, it's largely antigen avoidance, and it usually results in regression of the disease a lot of the times. And for patients with persistent symptoms, hypoxia, or extensive lung involvement, like in this patient, glucocorticoids are recommended. And you can do prednisone 0.5 mg per kg per day up to 30 mg per day for 1 to 2 weeks, and you can taper it gradually over 2 to 4 weeks. In patients that don't respond to any of these treatment options, then you can consider immunosuppressive agents like azathioprine and mycophenolate mofetil, which were studied most with hypersensitivity pneumonitis. But most of the times people usually improve with antigen avoidance. And I think that is it. Thank you.
That was interesting, I have to say. I'm surprised we didn't think of that. Okay. So like I said, it's fine to anchor pretty heavily on things that we, common things being common. This is likely to be in our, well, I don't know if Dr. Bergoli was thinking of this when we were presenting the history.
It was a great case because, I mean, when you hear about somebody with pneumonia coming back, with similar symptoms, the first thing that you normally think is whether the diagnosis was correct or whether it was partially or not well treated for whatever reason. When you hear that this was not the first or the this was like the 3rd episode, right, of pneumonia, then you start opening up your differential. Why would somebody catch so many pneumonias? And then again, the answer is usually in the history, right? You need to ask more questions. She had birds.
Yeah, exactly. Thank you, everyone. I don't know if anyone has any questions. I'm just going to share the survey for this academic half day. If you see, excellent case. Thank you so much. We learned a lot today.
Thank you.